Can you hear me?
We can hear you.
Okay, good.
Yes, we can hear you, Julie.
Thank you for joining us tonight. We at MaskTogetherAmerica are honored and pleased to have these healthcare professionals as speakers here tonight. Dr. Dhaval Desai is the Director of Hospital Medicine at Memory St. Joseph's Hospital and a pediatrician hospitalist at Children's Healthcare of Atlanta, Assistant Professor of Medicine and Distinguished Physician at Emory University School of Medicine. Dr. Camille Clare is a tenured professor and chair of the Department of Obstetrics and Gynecology at Downstate Health Sciences University in Brooklyn, New York. Dr. Jonathan Levy is the chair of the Department of Environmental Health at Boston University. Dr. Yanir Bayem is co-founder of the World Health Network, professor and president of New England Complex System Institute. Dr. Angelique Corthals is a biomedical researcher and forensic anthropologist, associate professor at John Jay College, who is affiliated with Doctors Without Borders. With help from these wonderful speakers tonight, we at MaskTogetherAmerica ask for your help to urge the government to continue to educate the public about the deadly consequences of getting COVID-19 and extending this pandemic. Ending the emergency declarations would falsely declare victory. COVID is far from over. My husband went to India, contracted COVID when he was forced to unmask during security check at a crowded airport. Today is day 11. Though he got PCR negative test result 2 days ago, he tests positive again today. Even though he has finished a course of Paxlovid 6 days ago, he's staying isolated because I am immunocompromised with chronic kidney disease. Wearing a mask isn't a big deal for us. It's much easier than asking someone to donate a kidney to me. We need our government to make an effort to promote the combined benefits of ventilation, vaccines, masks, testing, isolation, and treatment. Between January 1st and April 5th this year, the CDC reported 37,861 COVID-19 deaths in the US. In 3 years, our country has lost over 1.1 million residents to this preventable disease. Over 250,000 children have lost a parent or a caretaker. At least 14 million infected with COVID are seeking care for long-term symptoms, according to a recent Washington Post study. Millions of long COVID patients have been disabled. Without funding for sickness prevention and safety net programs, this tragedy will continue to grow out of control. Yesterday, President Biden ended the declaration of national emergency, and he plans to end the public health emergency on May 11, knowing that the pandemic is not over. The White House directed the United States Department of Health and Human Services to free up $5 billion to fund Project NextGen, an initiative to expedite the development of new vaccines and treatment. Clearly, COVID isn't over in the US. Our Congress didn't approve the funding requested by President Biden. HHS took funding from diagnostic tools and other priorities to fund vaccines and treatment. The United States needs to invest in wastewater surveillance and filtering indoor air. We need effective diagnostic tools. We need to provide people with free masks and test kits. The end of emergency orders means the end of funding for all the things we need to end this pandemic. We cannot tolerate cutting funding for research, virus and surveillance, preventive measures, and treatment in a country where health care isn't free for all. Hospital bills can turn someone homeless in the United States. It is unacceptable that over the coming months, we expect to see 15 million being unenrolled from Medicaid and losing health coverage. Treatment and tests are unaffordable and inaccessible for people being abandoned by the social system. The US started to build a safety net to care for the working class during the pandemic. Most of these programs have been dismantled. Obesity, lung disease, chronic kidney disease, cancer, diabetes, hypertension, and other medical conditions make COVID-19 more dangerous. According to the CDC's list of risk factors for COVID-19, nearly 200 million people in the US are at high risk of severe COVID, and they are at greater risk because only 16.7% of the US population has received the updated booster, even though vaccines now cost nothing. It would be a huge mistake for President Biden to declare the public health emergency over. COVID denial will explode worldwide. If people must pay for tests and treatment, many simply won't. Those of us at high risk will be greatly endangered. We fear this country, unprepared, will suffer another deadly wave. Our president will be blamed for the lives lost from the next dangerous variant. If you haven't signed our petition, please do so. We want to hear your concerns tonight. Hopefully, our speakers will be able to help provide you with some answers. Now, I will pass the mic back to Sarah. Thank you, Sarah.
Thank you, Julie. We appreciate you being here with us, even though I know this is a hectic time in your household. So thank you for being here. All right, we fielded a couple of questions from Facebook, Instagram, Twitter, anywhere that people are sending us questions. So I'm going to start with a couple of those. But please, if you have any questions for our experts, you can click on the chat panel on the side, drop those in there, and I'll be happy to field those to our experts during the program. How can the most vulnerable patients protect themselves from a virus that will endanger them in the highest risk settings today when hospitals are allowed to remove mask requirements, especially for people who cannot take the vaccines due to medical complications? What would you advise them to do?
That's a really good question, and I can start off, and certainly we'll turn to my colleagues should they have any other feedback on that. You know, for our most vulnerable, our immunocompromised population, those that may have contraindications or reasons they cannot take the vaccine, this is a harder journey for them. This is an ongoing threat to them. So for them, even as the country loosens all restrictions, the three things I would still focus on is masking in public. If they can take any other vaccines for a flu, that sort of thing, those sort of vaccines should be still taken for preventing any other co-infections. Hand washing, hand hygiene is key, and social distancing. You know, social distancing 3 years later in the pandemic looks very different than when it did initially, but obviously utilizing the general precautions of ventilated areas, masking with a 95 in tight spaces. That's what our population that's really at risk needs to continue to do. As Julie mentioned, the COVID rates are still going up. And while it's mild for a lot of people, this is the patient population that we really do still worry about. So they need to take extra precaution.
Sarah, I would just add, because I can speak to my patients that are interested in pregnancy or currently pregnant or lactating. For my patients that may still have concerns because there's still fairly low rates of vaccination in pregnant individuals, especially if certain groups, Black pregnant individuals, have some of the lowest rates of vaccination. Those same recommendations that Dr. Desai mentioned, we highly, highly recommend because pregnant persons are especially vulnerable for themselves as well as their unborn children to be at risk. So definitely highly emphasize what Dr. Desai just mentioned, especially if there's still lack of vaccination confidence is what I like to say for patients that are currently pregnant or interested in becoming pregnant in the near future.
I can add one thing as well for patients who are vulnerable is there's masking and masking. So very importantly, upgrade your mask game. Nothing under N95, make sure it's very well fitted. There's a million resources online that can help you fit the N95 properly. And I would go all the way up to N100 and elastomeric masks that are even more efficient than the N95. If you are immunocompromised and you cannot be vaccinated, that's definitely the way to go.
Agree with all the previous speakers, and just to amplify one point, looping back, if there's any setting in which masking should be continued, it is the healthcare setting, where you have the most vulnerable individuals coming in. Not everyone can wear masks who's entering the healthcare setting, and clearly whatever the prevalence of COVID is in the general population, it's going to look different in a healthcare setting where people are obviously coming when they're sick. And so it's certainly easy to say advocate and lobby and so forth, but of the various measures that ought to be retained, independent of what happens with the end of the public health emergency, that seems like a wide and prudent measure to keep not just vulnerable patients safe, but staff at the hospitals as well. Having a short-staffed hospital because people are out sick is not going to help with the healthcare system or taking care of the vulnerable either.
All right, thank you so much for those good answers. All right, our next question I'm going to direct towards Dr. Clare. The healthcare data showing maternal mortality climbed to a peak during the pandemic and disproportionately high rate increases in communities of color. A federal law passed in 2020 prohibits states from ending coverage for Medicaid enrollees for the duration of the COVID-19 public health emergency declaration. Ending the PHED will reduce postpartum care of Medicaid enrollees in 8 states that haven't taken action to extend coverage. What will happen to new mothers in those states? Those states are Alaska, Nevada, Montana, Idaho, Nebraska, Iowa, Missouri, and Arkansas.
Yes, what we saw in the most recent data from the CDC and other groups is that specifically on top of the already crisis of maternal mortality, COVID-19 pandemic, on top of that, continue to increase the rates. And in those states that you mentioned, Sarah, where there is not Medicaid expansion, especially for 12 months postpartum, which is the most vulnerable time for pregnant individuals or recently pregnant individuals, that's the highest rate of death in the 12 months postpartum. That lack of extension of Medicaid coverage is just a huge disaster. And so as a OBGYN myself, as my colleagues who are obstetrician gynecologists, we continue to work with our medical specialty society, which is ACOG, the American College of Obstetricians and Gynecologists, to continue to work with our legislators, especially in those states, to advocate for Medicaid expansion for 12 months postpartum for all individuals. Even in my own state of New York State, it was originally passed, and it wasn't even passed originally for all individuals. So immigrant individuals were initially not included in that group of people until we continue to push for every individual. So we need that for all states. So those are listening who are on the call, who are listening live in all social platforms, we have to speak to your individual legislators to continue to advocate for Medicaid expansion for 12 months postpartum, in addition to the other measures that we're talking about tonight. Because COVID, on top of the already crises of maternal mortality and morbidity, is really just amplified even further. And the one other thing to add to that is continuing to advocate for other supportive measures to look at why we can look at why, mothers are unfortunately passing away during this period of time. So things such as maternal mortality review boards or review committees in all states, and even in certain cities, for example, it's in DC and New York City and Philadelphia, that's where we need to continue to look at these cases and figure out why individuals are passing away, unfortunately, because of multiple system issues.
All right, thank you for sharing. I'm going to send the next question towards Dr. Levy. Why does our country force workers to return to work or school when they are contagious with COVID? We know people are still positive after 5 days. How can a worker or student protect themselves when transmission is so high?
That's a really good question. I don't know the answer to it. What I can say is a couple things. One is that we do know from lots of studies that a good number of people are still infectious after day 5. Some estimates have been 15%, 30%, it varies by study. Probably the majority of people are not infectious at day 5, but many, many are. And so the decision to move it from 10 to 5 days, I think, was frankly just to get the economy moving, get more people into the workplace, and accepting what is frankly an unacceptable risk of putting infectious people into the workplace. So in thinking about how you protect yourself, if you're the person who has COVID and you've hit day 5, you should certainly test at day 5. The requirements from CDC don't state that you have to, but obviously testing is a key way to find out if you are remaining infectious. So if you still have those test kits and you have the financial ability to get additional ones, certainly test. If you're infectious and you have the ability to stay home from work, by all means do so. If you, for whatever reason, have to be out and about when you're infectious, be smart and be prudent. Wear the highest quality mask you can, per the earlier speaker. And from the flip side, if you're someone who is in whatever workplace setting, home setting, and there may be people around you who could be infectious, again, that's where you have to have your masking game as good as possible, ensuring that ventilation is adequate in your space. There's certainly a lot of commercial and other spaces where indoor air quality has not yet been adequately addressed. So hopefully, to the extent that things can be addressed structurally, that's great. Opening a window is sometimes a good stopgap solution, or using a portable HEPA filter. So, taking the measures that you can to get the virus out of the air as quickly as possible, wearing a mask so you're breathing less of it in. And again, people utilizing tests to determine whether you're still infectious, not an arbitrary cutoff date.
So there's a published study that was just released, I think 2 days ago, about surfaces in household where one member of the household has COVID and the others do not. Surfaces, it turns out, are actually really important. So cleaning surfaces is another important part of the prevention when you have a case within the household.
We've had some physicians test positive for COVID in the last 3 months when our return to work guidelines have changed, and despite testing negative at day 5, when they come back, we are asking them to stay N95 masked at least till day 10. And obviously with patient facing, and also when they're in our office working, to remain masked and try to get them home as soon as possible to do remote work as much as they can. So I think every group within an institution, regardless of your workplace, needs to make that decision. I agree with Dr. Levy on that. I think the decision was made to make these guidelines to get the economy back moving, and the workforce being so depleted in certain settings, whether it be our teachers, our healthcare workers, our nurses, our physicians. It's just how I'm not saying I agree with this, but how much more work can they miss when already a skeletal workforce, and we're facing that every day. So I think it's very complicated, unfortunately.
Thank you, doctors. All right, I'm going to direct this next question to Dr. Corthals. Why don't we mandate masks in flights when we know that a study has shown that over 96% of tested airplanes had COVID virus in their wastewater?
Right. Why? It's pretty obvious. It's purely a commercial thing. Has nothing to do with medicine. The airlines have, in fact, lobbying the government to remove the mask mandate on flights much earlier than it was even comfortable imagining. This is the reason why mask mandates were lifted last year. So in flights, it makes no sense whatsoever. The most problematic moments in a flight are when you are sitting, when the airplane is sitting at the gate and it is taxiing, because at that point the air circulation has not been switched on, switched to the recycled air, which hopefully are going through HEPA filters. Not all airlines have them either, and the whole UV HEPA filters in most airplane is actually more a myth than a reality. Although they do have, most airlines have HEPA filters, but they are they're not as clean as we think they are. Takeoff and landing. So whether your plane, anytime your plane is on the ground is when you're going to have, if you have one of those little CO2 monitors, this is when you can see your CO2 monitor just go right up as your plane is taxiing and stuck at the gate, or if you have that nightmare stuck on the tarmac. It makes absolutely no sense. I've taken many flights since the beginning of the pandemic, each time with a very well-fitted N95. Some flights were very long, and I did not eat or drink. Drank very little, and when I drank, I actually used that sip valve with a straw. So it's uncomfortable, but I never got sick. And to me, it's worth the discomfort, I have to say.
All right, I have a question I can just direct to anyone who feels confident answering this one. Masks are politicized instead of being promoted by the government. Even hospitals are dropping masks as new variants are emerging. People have stopped testing. Biden didn't include in his budget to fund wastewater surveillance. More than ever, we need real-time monitoring of the virus. Instead, the existed fragmented system might be shut down due to lack of funding after 2025. What will happen when the virus mutates into a serious form?
It's already serious. I'm just saying.
Yeah, I don't think any of us know what's going to happen, except it is a very worrisome situation. I think the reality is that Biden or whoever is in charge of the country was going to have to end this sooner or later. When I don't, whether he obviously it's happening now, but could it be done more state approach where we still have an organized office that's kind of coordinating all these agencies and the response? And I do worry. I worry that the next, from fall and winter comes around, that's going to be our test. Obviously, we've had summer variants in the past, the Delta variant in 2021, but I think, and it may be hopefully that as we keep having variants, the cases will be milder. But as Julie's already talked about, we have immunosuppressed patients who are going to certainly need to be more vigilant. So I think we're going to continue to need a lot of attention on this. I think it's important for clinicians like me and my colleagues here on this call to stay abreast of all that and be proactive on that. I don't think any of us are going to be able to change, despite lobbying change, what's going to happen next month with ending this. But I always say what I learned in medicine: stay away from the politics and focus on the patient, right? So that's what we have to keep doing for ourselves, and I think that's what we need to stick to. But I welcome feedback from my other colleagues here.
One of the more incisive things that I read about the end of the public health emergency, which I think pertains to this question, I think it was Josh Sharfstein from Johns Hopkins, who said, what we've done the past few years is really taking a public health approach to the pandemic. We are now ending that, and we are taking an individualized healthcare approach to the pandemic going forward. And so, we're treating a public health problem increasingly like an individualized issue within the healthcare system of the United States, where there are clear disparities in the nature and type of healthcare one can access. And so it's pretty clear what path that's going to take. And I mean, to the question that was written, the future is unclear. Things may get milder, they may get worse. We might only see winter waves. We might see other seasons. It's very unclear where we're going. I think what's clear is, by pivoting to strictly a healthcare approach, there are a lot of people that are going to be left out, and by taking prevention off the table and focusing on treatment, we're going to have certainly more cases, more transmission, and more problems than if we really emphasized and funded and prioritized prevention measures. So I don't have a solution to that other than just to reinforce the value of public health in dealing with a public health problem, which sort of ought to be self-evident, but clearly is no longer.
Talking about the nuts and bolts, scientific nuts and bolts here, my spouse is an evolutionary biologist, and I do biomedical research. So I really, have been taking a good look under the hood of the SARS-CoV-2 virus. And the problem with that individual you approach to public health is that we are denying we're in deep denial in terms of the catastrophic public health issue that we're going to have in the next 10 years with all of the people who may not have developed immediate secondary effect of having been infected, especially multiple times, systemic effects such as on the neurological system or the cardiovascular system. And this is something that, we've been looking at it, and we've been doing experiment with the SARS-CoV-2 virus. And we have noticed that none of the experimental subjects that, we've used rodents, obviously, but none are doing well after multiple exposure. And it's also denying the evolutionary history of viruses, particularly of coronaviruses, which are very well known for not really going into a milder form. So right now, the Arcturus variant is wreaking havoc in the southern hemisphere, and particularly in India, where Julie's husband just came back from. And in India, a couple of days ago, they actually reinstalled the compulsory mask, the mask mandate, because of that variant. But what we're not really at the public health level, what we're not responding to is we're not responding to the science. And this is the outrageous part. This pandemic has been a complete failure of two things. The first thing has been communication. Communication has broken down, whether it's from agencies that should be in charge of public health to the public, and even from the nuts and bolts scientists being able to communicate to the administration. None of that has, all of those systems have broken down. And I honestly, I've been trying to talk to colleagues about this, and we don't see a solution out of this. The only solution there is actually for groups like MaskTogetherAmerica and for other groups to advocate. And that's about the only thing that we have left at this point. Because the big agencies, WHO is not doing anything, CDC is not doing anything. They're pretending to do a lot of things in the background, but they're not doing anything in terms of communication. I just talked to a friend of mine today to explain why the mRNA vaccine was not produced fast. And that's because we've known the mRNA since the first SARS epidemic. And so I explained, we explained the whole history of this to her. And she said, well, why is it that it's not known? Why is it that we don't know? We, the public who are not scientifically educated, why don't we know this story? And it's out there, but you really have to scratch to see it, right? So I don't want to hold but I'm sure my colleagues have many things to say about this right now.
I mean, just to add a little slightly separate point, and in addition to what Dr. Corthals has mentioned, continuing to include pregnant persons in clinical trials. We were so really in a quandary of how to advise patients for such a long time, except for the bravery of our pregnant colleagues who are physicians and scientists who obtained the vaccine in the earlier stages that we got information. So continuing, for me, speaking as an obstetrician all day, every day, we have to continue to advocate for our pregnant persons in these trials so we have the information and not be these unfortunate, have these pregnancy biases to the point that we can't get the data that we need to appropriately advise patients how we need to. So very separate point, but really, really important to continue to advocate for our pregnant persons in these trials so we know how to advise our patients.
I'm going to take a question from the chat panel here. Brittany Porter wanted to ask, does anyone know about outdoor airborne transmission? How common is it with the latest variants? And are there any thoughts on this new Arcturus variant? Do you think it's a new pandemic?
I mean, I can take the former question. I don't have any real insight on the latter. I mean, we know that, you know, indoor spaces and poorly ventilated indoor spaces are much riskier because, you know, COVID is transmitted in the aerosol phase, but that doesn't mean that outdoor spaces are 100% safe. It sort of aligns with intuition. If you're in a large crowd of people, if you're at a concert and there are many people around you clustered in tight, you know, if one of them has COVID and they're next to you for hours, there's a good chance that you'll get infected. If you're at a park playing frisbee with your kids, you're fine. So, you know, there's nobody near you, and, you know, wind and dispersion are your friends. So it meshes with intuition. I think maybe we were too far on one end of the pendulum early on of not recognizing that outdoors was a lot safer than indoors and sort of curtailing outdoor activities to a greater extent than needed to happen early on. I think now maybe the pendulum has swung too far where people think as soon as I walk out the building, I'm invulnerable. Nothing can get me. So we just have to be smart and sensible. Again, avoid large crowds and poorly ventilated spaces, and maybe sometimes it's large crowds or poorly ventilated spaces if you want to reduce your risk of infection.
I can take the second part of the question about Arcturus. Arcturus is interesting. Arcturus has only 2 mutations that makes it different from the previous so-called Kraken variant, and but those 2 mutations makes it really ultra infectious. Unfortunately, as Jelly's husband has found out, and those 2 the understanding whether it's a new pandemic or not, it's not really a new pandemic, but it is almost a new virus, because if you look at the distance between the original SARS-CoV-2 virus and look at how distant it is from how distant the current variant, so the Arcturus variant is from that, and you look at the distance between the genetic distance between SARS-CoV-2 and the first SARS, actually the new variant is further away from the original variant of SARS-CoV-2 than SARS-CoV-2 is from SARS the first. So it's almost now a SARS-3 that we have on our hand. That's evolutionary speaking, obviously. Now, the problem is the uptake of boosters and the efficacy of the mRNA vaccines in terms of how it's going to react to Arcturus. So India is not a very good test case for us, because India has been testing many different vaccines, including a new nasal vaccine that has been circulating there and in China for a couple of months now. So there's that interaction that doesn't make what's happening in India exactly translatable to what's going to happen when it's firmly established here. We're going to see an uptick for sure. It's not going to be advertised, but we're not going to know about the uptick, of course, now that we have no way of really monitoring what's happening, and that is the biggest problem. The other big problem is we don't have adequate testing. So our PCR tests, our free PCR tests, are going to disappear with the public health emergency. And so nobody is going to really go ahead and test with using PCR. And our antigen tests are not going to be efficient for this. They're already struggling with the current variant. They're not going to be good for Arcturus. They're only going to be good once you are really firmly infected, where your viral load is so high that it's overwhelming the antigen test. But by then, you will already be so infectious that you will have spread it all around you without knowing it if you don't wear a mask. So we'll see. I don't think it's going to be, the Delta wave, but we will see an uptick for sure, and the wastewater monitoring numbers will show that. But it's not yet firmly established in the U.S. It's still on a fairly low level. I hope that helps.
Thank you so much. All right, we're going to go to a question from, I did not write down the person's name. I can find it. Can the speaker say more about the surface cleaning issue? It was a big focus, but then the lack of evidence of transmission on surfaces meant it has largely been dismissed. That question is from Debbie S.
Well, I can take that again. Sorry. I actually read that study that was published 2 days ago. And yeah, so fomites, which is basically how any kind of infectious substance gets transmitted by touch, rather than airborne or any other way, are really actually turned out to be very important when you are in a household setting, so sort of concentrated setting, which means that we really should take care of healthcare settings, because even though it's not a household, you still have those very concentrated settings, we know that nosocomial COVID is a thing. From the numbers that came out of Britain, a lot. But I think it was something ridiculous, like almost 50% of the patients who went into the hospital without COVID came out with COVID, and part of the reason for that can be associated with surface infections, so fomites, infection from fomites in healthcare settings. So yeah, they are far more important than we thought at the beginning. Although I like to say that I was advocating against fomite from the very beginning, but these particular variants makes it even more important to disinfect surfaces in close contact settings.
All right, we have another question from Brittany. Why are Biden, the CDC, national institutional leaders encouraging COVID to spread when they know that it's so often permanently disabling? As someone with ME and CFS inflaming my immunity and smothering my aerobic metabolism for the last 19 years, whose friends have literally laid in the street outside the White House, I truly don't get it. Even from an oligarchic economic view, why they would want to mass disable the workforce. Any thoughts?
No major thoughts, but I think they're trying, and I don't vouch and agree with it, but I think they're trying to turn COVID and transform it into what we think as seasonal flu, as what we think of other diseases that now we have vaccines for. I feel they're trying to normalize it, and that's where we're at. Is it too premature? Probably, but I think it's the fact they're trying to normalize it and help the country move on, whatever that means, honestly. That's my personal take.
Yeah, that's actually a really good point. Instead of normalizing mitigations, they're normalizing the virus, which is like,
right. That's
no.
right. That's right. That's
no,
right.
It's the contrary. Swap that.
Laura Sabadini would like to ask, is there any reason at all to think that newer variants would be milder variants?
From an evolutionary standpoint, absolutely not.
I'm not an immunologist. I have studied and learned, Dr. Corthals, I'm just going to say my one sentence here, but disagree with me if he does that. as viruses keep mutating, we do see them getting weaker clinically at times in terms of their manifestations. And I think we have relatively seen that. There may be a variable with the vaccination and everything that we've seen, but being on the hospital front, we have less than 5 patients in the hospital right now. When we have peaked during COVID, on average daily in my local hospital was 130, 140 admitted. So just to give you that perspective, but I'm not, like I said, I'm not the expert on that.
So from an evolutionary point, there's no reason for viruses to become weaker. What they end up doing is they end up sort of flaming through the population and leaving essentially the more immune competent individual stronger. In this case, so this is called natural selection. In this case, of course, we have the vaccination, which throws a complete wrench into a lot of the natural selection process. However, there's still some of that going on, and that plus the vaccine means that we have fewer cases in the hospital, but that doesn't mean that the virus is down, and that doesn't mean it's weaker. In fact, it can actually recombine and come back much stronger. And by letting it go rampant, we actually risk a recombination that's going to produce something that we have no immunity and no vaccine for.
Yeah, that's a better explanation. Thank you. I think it goes to show that we keep vaccinating ourselves, right? And we have and keep advocating despite the emergency ending for disease prevention, so we avoid what you're describing. Is that a right way of looking at it, Dr. Corthals? Yeah.
Yep.
Are we going to see any further push to improve ventilation and air purification, like the far UVC lights, HEPA filtration, air exchange machines? One whole state, Illinois, seemed to get in and have donated high-quality air purifiers to be used in all of their public schools. Do you think this will be a trend going forward? We need large-scale non-pharmaceutical interventions. We've spent enough time pushing the onus exclusively to individuals. That's from Christina A.
I can start on that. Indoor air quality is one of my major areas of research, and so I would certainly hope that is the case, and I certainly think the case can be made above and beyond COVID, right? Well ventilated indoor spaces, workplaces, schools, otherwise, are better for a variety of infectious diseases. They're better for air pollution, which has a number of effects, and they're actually better in terms of learning and productivity. So even for folks who are dismissive of the importance of COVID infection, having a more productive workforce should be one of those rallying points. There's a group right now out of Johns Hopkins that is actually developing a model state indoor air quality act intended to create a template that states could follow to try to address indoor air quality, and knowing that the likelihood of a federal indoor air quality act with teeth, not just sort of guidance and recommendations, is fairly minimal. So I think the effort in Illinois was frankly amazing. I think that's a wonderful and concrete step to get clean air for our schools and kids. I think things like this Johns Hopkins effort are really important because it shows tangibly what can states potentially do to put forward indoor air quality regulations that are actually meaningful, tangible, and just kind of acknowledge all of the legal and regulatory complexities. So there are a lot of issues. I can see some comments coming in the chat about just the sheer expense of upgrading HVAC systems in some buildings. That's undoubtedly true, but there's a spectrum of measures that can be taken. Again, the Illinois measure, if I recall correctly, was actually putting portable HEPA filters into buildings, which is not as good as larger systemic changes, but it is a really important way to be able to clean the air. So I would hope that there's a bit of increased attention toward indoor air and perhaps an increased acknowledgement that we spend 90% of our time indoors, and we ought to be breathing clean air in those settings, whether related to COVID, wildfires, or anything else.
Thank you.
We have a question from Debbie S. Echoing Christina on the need for clean indoor air standards and tools, can Dr. Levy speak about what we might expect or hope for from the still pending OSHA standards?
I don't know the answer to that. I'm not an occupational health expert. I'd kind of pivot it back to this Model State Indoor Air Quality Act effort, which is not the end all be all, but trying to, I think, take a broader lens at a wide range of buildings and settings. So we certainly need better occupational standards related to ventilation and indoor air quality. I think we need this broader lens to recognize that we need healthy buildings and the buildings that we collectively spend time in. So I don't know if anything is going to be percolating out of OSHA. I would hope so. I'm skeptical, frankly, because of everything else that's been happening in terms of kind of downplaying the importance of either short-term or long-term investments to deal with COVID and other infectious agents. But I think there should be attention and pressure at the local, state, and federal level to have healthy indoor spaces. Again, our children should be going to school in buildings that have healthy indoor spaces so they can not be absent from school, so they can learn while they're there. And this should be a no-brainer. And the question is just how to fund it, support it, and maintain it, recognizing that this is a non-trivial effort, but using some of the infrastructure of things like an Indoor Air Quality Act at the state level to allow for a bit more monitoring, oversight, and then intervention measures that could happen in buildings that are shown to be out of bounds.
Zena would like to know what can be done for those who have chemical allergies to the vaccines. Can the vaccines be developed without PEGs or polysorbates? She can't get the vaccine because of her chemical allergies and she needs help.
So I can answer to that because I've been actually working on different vaccine platforms. Probably the best hope for people who have these types of allergy like you would be the vaccines for respiratory diseases, not just COVID, but the flu as well, coming up down the pike, and that have been pushed by the COVID pandemic, which are, I mentioned them briefly, but the nasal vaccines contain less adjuvants than other vaccines, and are less likely to cause allergies. They're also not an injection, so it has the mechanism of the response of the immune system is quite different, which means that you'll probably have an easier time taking the vaccine.
Dr. Levy, Brittany would like to know, is it safe for vulnerable folks to sit, dine, hang outdoors, unmasked, with someone who has more potential exposure than we would be comfortable with indoors?
I mean, these are always tricky questions, right? Because it is safer, but right, safer is not the same. If what you're looking for is it zero risk to dine outdoors, right? The answer is no, right? Is it lower risk to dine outdoors unmasked than to dine indoors unmasked? Of course. And so it comes down to your level of vulnerability, your risk tolerance, and a host of other factors. Again, certainly any ability to gather outdoors is better than gathering indoors. You can take supplemental steps like asking folks to rapid test before they come join you, adding in the layers of protection that you could. But I think having a blanket, if you do X, Y, and Z, your risk will be zero, I think would be, going a bit too far.
I agree. I can tell you a small anecdote from a conference that my spouse attended. The The conference required testing, and the conference required masks indoors. So most of the conference goers went outside to have a conversation and have a meal, thinking that they were safe. Turns out that one of the people sitting at a table of 15 had COVID, passed it on to her direct neighbors, and it started a cluster of COVID cases, despite all of those mitigation that were in place, but people thinking that people having sort of a magical thinking about, I'm outdoors, therefore I can do whatever I want, and I can just stand very close to the person talking to me, just projecting all kinds of things in my face. This is what Dr. Levy said earlier on about your risks, and it, if you're talking to somebody really close by and you're in a sort of crowded setting, but outdoors, you're going to have a much more elevated risk of catching COVID if one of the member of the party had it. So turns out that on a conference of about 500 people, about 46 COVID cases could be related to that one sitting.
For monitoring wastewater levels of the virus, can the new variant be detected?
Yes, PCR and sequencing can detect it quite easily.
At least we have that going for us, right?
Woo-hoo,
all right.
Yeah, but we have to have that. We have to have the fun to keep that going, and this is the
absolutely
the public health emergency is stopping.
Yes, I agree. I am lucky to live in an area that has the wastewater testing pretty readily accessible to the public, but I'm hoping that that doesn't go away.
Yeah.
All right. Jenny would like to know, are there any prophylactics in the pipeline since Evusheld is discontinued, or are there too many variants now to keep up with to do so?
So I feel like I'm talking a lot, but it turns out that this is something that I'm reviewing for Doctors Without Borders, because we're looking at the next generation and of diagnostics, vaccine and RX, so the prophylactics. There are new antibodies, monoclonal antibodies and polyclonal antibodies actually coming up on that are currently in clinical trial for the newest variants, or for that are more resistant to newer variants, but they are, I believe, in stage 2B, so they're not quite there yet in terms of when they're going to be developed. Right now, the only real tool that we have for prophylactic is Paxlovid, really, and even that has some issues, and the public health emergency lifting will add those issues. The biggest issue with that is the price of it. People are going to be really surprised when they're going to find out how much it costs.
Heather would like to know, are you aware of any grassroots direct action or advocacy campaign that has been successful in pushing an institution like a school or a hospital, a county or a state towards more precautions? What's the best place to direct our energy?
I don't have a clean answer to that question, which is a really good one. I'd look back to something earlier. I mean, there's so many different things to try to tackle, but I mean, to me, the maintaining masks in healthcare seems like an important one, where you can have really compelling narratives from different patient advocacy groups and other groups of individuals who would be adversely affected, as well as people who are working in the healthcare industry and would also like to see masks retained. And so I think there are a number of constituencies who could be activated on that point, and where there, still are considerable barriers, but maybe not as much structural pushback as some of the other possible intervention areas. And I think some of the people in the chat are mentioning that there have been cases where even where masks in healthcare were rescinded at the state level. Local hospitals or municipalities did maintain masking. I know Los Angeles County was one, places in Seattle were mentioned. So it does, at least personally, seem like that's one area where some focused local effort, pulling together a variety of different stakeholder groups, might be able to make a difference in the near term.
Dr. Corthals, Susanna would like to know what you anticipate happening to immunocompromised people in the next 10 years.
Yes. So just very quickly, I'm putting the link to the study about the fomites, and somebody asked me in the chat, so I've put it in the chat. Sorry. So about the immunocompromised, so I actually answered partially in the chat. Right now, there's nothing. There's nothing to protect you. I'm afraid, and the picture for 10 years down the line is quite bleak. But the one thing that is not bleak, and I think that this is where you should push so that the future is brighter, is that the only thing that you can do is advocate, and you need to advocate for the normalization of mitigation for all infectious agents. I mean, you know, people are talking about the flu like it's some sort of benign virus. The flu kills 250,000 people a year. That's not benign. That's a lot of people. And if we could avoid getting the flu, that would be great too, right? So the only thing that needs to happen right now with immunocompromised people, and this is where social media can help instead of hinder, is to find each other and organize and do exactly what Mask Together America has done, what Julie has done. You have to find an energetic leader like Julie and rally behind that person and make sure that you keep pushing your representative, your political or your elected representative, whatever, whoever they are at all level of government, from local to federal, to state to federal, and keep pushing this normalization. I mean, you know, masking in Asia didn't come overnight. For example, this actually followed a pattern that was pushed from many different outbreaks of infectious diseases, not the least of which was the first SARS, which we barely knew about. I mean, barely anybody knew about until SARS-CoV-2 hit. And then we started looking at SARS-1 and it's like, oh, that many people died in Asia? Oh, wow. And Toronto was on lockdown? I had no idea, right? So we can be very insular. But the great thing about this pandemic, even though it was a massive failure at the public health level, is the fact that it got people to rally and to organize to protect themselves, where public health organization completely failed. So that you know, obviously we are working on immunocompromised patient and how to have better vaccines and how to have better tools that allows us to mitigate the seriousness of diseases, but that is something that I can't predict for all the way for 10 years. The best thing that needs to happen right now is advocacy.
I think, just to echo that, we are never wrong for using our voice. Always use your voice, whether it's in your church, your local school, local community. I'm a firm believer that good health starts in the community, and start local, start small, start in your circle, use your story, use your knowledge, and that's what we really need to do. That's how I would start.
absolutely. In fact, we Doctors Without Borders was very, very good at finding that out with the HIV epidemic in Southern Africa, where everybody was scratching their heads like, how, we're not reaching anybody, we're not reaching. And so they started through the community rather than a top-down approach, it was a bottom-up approach of public health.
We have a question from Laura. She would like to hear the experts' opinions on why hospital executives and leadership were lobbying to end universal masking in healthcare. What are your thoughts, and do you happen to know at all what logic these hospital and healthcare system lobbyists were using?
I don't know, and I don't think it's all of them. I think it's pocketed. And I'll speak locally. That's a very staged approach. What we're doing, we're still using mass patient facing, and there's guidelines to follow on that. I don't know that it's a unanimous across the country. Every hospital executive team is asking for this. Without knowing the granular details, I imagine there's a business model behind it with PPE and all that. I don't know the answer to that, but I think it just depends on the institution. I think somebody said before, it's a business, right? At the end of the day, all of this is a business. I read that in the comments somewhere. So that's why we have to keep advocating for ourselves. That's the best we can do in using our voices.
Dr. Corthals, how soon do you estimate that rapid antigen tests will become far less useful than they currently are?
Well, any less useful than currently, and there won't be any. They won't be useful at all. Their use right now is very limited because of the current evolution of the virus. So if it continues evolving, the ones that we have right now, like the Binax, for example, or the ones that used to be free, are going to be useless within the course of this year. So we're going to need new tools, and this is what I pointed out at the last forum, and this is what I keep wanting to point out is that the administration wants you to believe that we have all the tools to fight this pandemic, and obviously they're contradicting themselves because they just gave $5 billion for better vaccines. Obviously, they know that's we don't have all the tools, but one of the critical tools that we never think about is the diagnostic. Exactly what we were talking about, the antigen tests. They are. If you look online right now and search for a PCR quality test like the Detect test or the Lucira test, what you'll find out is both companies are going under. And it's a complete shame. All the companies that started the at-home diagnostic tests, particularly the PCR quality tests, are filing for bankruptcy right now because there was no forethought into the future and what to do after after their original products, and now that the public emergency, health emergency is going to stop, the market is just crashing. For the demand for these tests is crashing, and so there was no backup. All of those companies, by the way, you should know, were funded originally with taxpayer money from the public health emergency funds. And it is a damn shame to see that they are going under. I've been talking to both Detect and Lucira, asking if we could use their technology and reroute their technology for a multiplex test, for example, testing the flu, testing adenoviruses, testing COVID, all of those onto the same platform. And they're not interested because the market is not big enough. So it's all comes down to funding and perception of what is important in healthcare as well.
Holly would like to know, how much longer do you predict the pandemic will last at the rate we're going now?
Well, I think the virus is going to keep going if it's unchecked, right? If we keep a very low rate of vaccination and don't have better vaccination that prevent transmission, it's gonna keep. It's what we're gonna have is ebbs and flows, but the level is gonna stay sort of high. So actually, a good example of how viruses do not become milder. The flu comes back every season, ever stronger, a new strain, right? Is it going milder? It's not, right? So in that respect, we can imagine we're going to have a situation like that with this virus, where you're going to keep having a higher baseline of ebbs and flow and of waves and troughs into the population. Again, the important thing is pushing for better tools, making sure that we get funding for better tools so that we can fight it to the point where we can at least keep it in check and stop the transmission. Lowering the R note, that's been the goal from the very beginning of the pandemic, and it should still be the goal.
Elle would like to know, are there any ideas on Novavax updates and availability compared to mRNA and the bivalent Novavax booster? I heard it has a broader spectrum coverage, but I don't know the availability and helpfulness with new variants.
So I can speak on the Novavax. I also wrote a little thing on in the chat, but so Novavax is different from the mRNA in that it's a protein-based vaccine. And the advantage of Novavax is, first of all, unlike mRNA, protein is a lot more stable. The other advantage of Novavax is that it covers a broader segment of the recognition of the spike protein of the virus, which makes it actually a more efficient more efficient vaccine. So last week I just received my 6th booster, and I chose to have Novavax as the booster because of the whole premise that it has a broader spectrum of coverage of the spike protein, no matter what the variants are, even though it's a monovalent rather than a bivalent. And yes, it is possible, Holly, to have a sterilizing vaccine for COVID at some point. I believe that the nasal vaccines will be the more likely to be sterilizing.
And that is what we're hoping to get out of that $5 billion in funding, right? They're working towards some sort of sterilizing vaccine?
Yes. I mean, the good thing is, I don't know if they're going to reinvent the wheel from what they have in India and China right now, or what they're having on trial in India and China. I'm kind of hoping that they're going to collaborate, particularly India, because India is an absolute power horse in terms of biomedical research and production of biomedical products. And so I'm really hoping that that's how we're going to get a vaccine, a sterilizing vaccine fairly soon.
Susanna would like to ask, organized advocacy is a lot of responsibility, and not everyone is in a position to organize. What can immunocompromised people expect will happen to their bodies, brains, nervous systems as a result of trying to avoid getting sick, but being isolated, separated, and forced out of shared public spaces?
So I think that the physical part is one thing, but if you're avoiding all of that, and if you're avoiding public spaces, then you're avoiding the disease that can put your life in danger. But I think the greater part of what's happening to immunocompromised people when they have to avoid public spaces, when they have to take all of those precautions because no one else is, and no one else cares about it, is the mental health problem. And I think it's something that is not being recognized enough, and what a burden it is for immunocompromised individual to constantly fear and to constantly go about in a world that doesn't care about them. Right? And so this is why it's important to find your people, and the best way to do that is through social media. Find your people. You'll always find a charismatic leader. I mean, I found Julie, for crying out loud. You must find this, because if you don't find your people, you can't take that burden on your own. It's just going to do terrible thing to your mental health, which we know is going to do terrible thing to your physical health as well. So organized. You're not alone. We are there. We are fighting for you. But it's important to know that we are there and organize.
And speaking of community, one of Mask Together America's members, Dr. Caitlin, runs a Discord channel called the COVID Precautions Community. It used to be a Twitter community, and then she wanted to move to Discord when Twitter started becoming less reliable. So if anyone is on Discord and they want to join that, I dropped the link in the chat. All right, our next question is for Dr. Desai. Dr. Desai, do you think schools should require vaccination against COVID-19?
Yeah, I don't have expertise in this space. I mean, I personally think it's a wise idea, just as we try to get flu vaccines in place for kids and a host of other vaccines, right? Normalizing vaccination for the pediatric population seems like a smart idea. Again, I think our vaccination rates for our kids are quite low in many communities, and I think this should be something that we try to prioritize.
Holly would like to know what the best brands of rapid and at-home tests are.
Well, Binax is good. It's probably the most. Yep, Binax Now. That's the one. Binax Now is probably the best out there, the most reliable. The next one, but you will not. Yep, the popsicle. And the next best, but you probably not, Lucira, if you can find it. I know that Lucira is now being sold by the company at a huge discount, so you can get quite a few tests. I think you can get them now for $10 per test, and they're a little bit more accurate. But yeah, Binax is the best.
Dr. Levy has to leave in just a few minutes, so Dr. Levy, is it okay if I just give you the last question in the chat that was directed towards you?
Sure. Basically,
what your take is on the physiological changes happening to the immunocompromised and the long-term impacts?
Yeah, so that's outside of my area of expertise. So I think I'd defer to others on the call. Again, I come more from the environmental health side of things than I'm from the medical side of things. So I'd have to hand that off to somebody else.
All right. We are really appreciative of you being here, Dr. Levy. Thank you for your time. And we are very appreciative that you were able to spend this evening with us.
The only thing that's available from CVS, they can give you inaccurate result. Very strange. And you can read the review online. People are all getting like inaccurate result from this. you can be wrongly positive or negative. Because the way they test with the dipping the strip into the liquid, the whole thing is strange. So you can easily get 2 strikes, but you're still negative. So it's very easy to get an inaccurate result. This one's more reliable. But anyway, tests are going to be expensive for anyone as of May 11. And that's the biggest issue. Testing and treatment won't be free anymore. And that's not acceptable, right? We're entering a very dangerous time. When people stop testing, we won't know who's infected.
Yeah, it's kind of the dream of the previous administration. No tests, no cases.
It sounded crazy when he said it. Now that's the going public health narrative, it seems like. So it's great how much progress we've made.
It's obscene is what it is, yes.
All right, so going off of Julie's note just a little bit, I did want to just mention that because the public health emergency is ending on May 11th, if you have the opportunity to get your 8 free tests a month through health insurance, make sure that you do that the next month or two, because we don't know what the cost is going to be once the public health emergency goes away. Some people's insurance might still cover them. My guess is a lot of them will not. So a couple of days ago, I was able to put in an order just at Walgreens. There's a website. You can give them your health insurance information and you can pick up your tests through the drive-through. I know that that did not work for Heather, so it will depend on your health insurance and your specific situation, but that's a good resource if it does work for you, especially with the opportunity to be able to get those through a drive-through and not even have to go into the Walgreens. So we are in a spot now where we are down to our final expert, Dr. Corthals, and I don't want to put too much pressure on her to answer everyone's questions. So I think this would be a good spot to just give a final plug. Please sign our petition to help keep the emergency declarations in place. I'll drop the link to that in the chat once again. We are putting together a book of people's comments from the petition when you sign it. So if you would like to drop a comment when you sign the petition, that would be really great. They give us a lot of passion for the project, and it's good to hear from everyone and see what their experiences are. So please drop a comment when you sign. And a few of us are going to go to Washington, D.C. with Julie on April 27th to share all of that feedback with some elected officials to get their support and try to get some movement going in Washington. So let me grab that link to the public health declaration. And Dr. Corthals, if there's anything that you want to say kind of to wrap us up, feel free.
No, so, okay, the public health emergency is ending. It's bad, but as my other colleagues have mentioned, we have our voice and we are organized and we are like those chickens in Chicken Run. We can definitely, we can make things move and ensure that despite the fact that what we have right now are not adequate tools to fight this pandemic, and also include other infectious agents. By the way, we should, if we should use this pandemic as a stepping stone to prevent other infection and normalize mitigations to infections. For our immunocompromised friends out there as well, especially, I want to tell you that you matter, and we hear you and we see you, both at the nuts and bolts scientific level and in healthcare as well, and we'll fight like hell for you to have an existence where you don't have to hide away. and where you have to carry this burden on your own. And my parrot seems to agree. Sorry. That's the parrot that you're hearing right there. But it's important. And if, you know, I keep railing against social media, and I often take social media breaks because it's such a polarizing tool. But one thing we can do is use this terrible tool for advocacy. We have to keep advocating for better tools to fight pandemics, for better monitoring of cases, for clean air. Who knew that we would have to advocate for clean air? But it wasn't that long ago where people used to smoke in restaurants, was it? I mean, I think most of us knew that on this platform. So it can be done. It requires a tremendous amount of energy, but it can be done, and we will do it. Believe me when I say that those $5 billion that the White House has just released for the vaccine didn't come out of the generosity of the Biden administration. It came from advocacy, from people like us saying, hey, we need better vaccine if we want to quash this thing. Right? So keep going, keep doing what you're doing, keep advocating, get more people to sign up. Just be your awesome selves, and we'll get there in the end. We will get there because we're human, and we have a great way of being able to fight everything that comes our way.
Thank you so much, Dr. Corthals. Thank you all for coming. We really appreciate you. At the end of the day, you know, you are the ones who are making a difference. You're the ones who are part of our organization, who interact with us, who show up to panels, who ask thoughtful questions. You are the lifeblood of this movement too. So we really appreciate all of you showing up here. And we appreciate Julie being here, even though she is currently taking care of a husband who is sick. And Dr. Corthals for taking time out of her day and all of the amazing work that she's doing. So thank you all so much for being here. Sign the petition. The link is in the chat. Follow us on Twitter, Instagram, and Facebook. And we'll see you at the next one. Thank you, everyone.
Thank you so much for coming.
Thank you.